other influential members of the health tech community. Today's panel discussion topic is technology to improve the health of people and their communities. And while I acknowledge that the potential discussion points in this topic are vast, this conversation is not meant to be exhaustive, but instead to highlight key points among a few important areas for innovators, entrepreneurs, and investors to consider when designing, developing, and investing in technology that serves to improve health in communities. So I'll start by asking our esteemed panelists to provide a short introduction of who they are, their role in bringing technology to improve the health of people, and how they define the imperative to bring technology to impact health in communities. I'll start. I'm Lindsay Williams, president of Corliss Consulting, a strategy-focused consulting firm, and co-founder of MyUTI, a platform dedicated to creating a frictionless care continuum for people suffering from chronic bladder infections through consumer-directed access to advanced diagnostics. I've spent the majority of my career in startups, commercializing new products in the urology and women's health markets, in addition to serving as consultant and strategic advisor to other startups. I believe we are seeing an opportunity to leverage the Internet of Medical Things to bring technology to communities to improve health, both in ways that shift our system from sick care to well care, and in ways that allow for focused efforts on communities otherwise underserved. So right now I'm going to ask each panelist to introduce themselves, and we'll start with Adamika.
Good morning. My name is Adamika Arthur. I run a nonprofit organization called HealthTech for Medicaid. We bring payers, providers, policymakers, and entrepreneurs together to scale and innovate in the Medicaid space, and really came out of the need for, as digital health has been rapidly evolving and health technology itself has been moving over the course of the last 15 to 20 years, we haven't always thought about including healthcare ethics in how we've built this field. And so HealthTech for Medicaid has really come to be from ensuring that we include everyone as a part of our need to really expand the way that health tech looks. So our vision as an organization really is we're dedicated to supporting innovation in Medicaid. Medicaid is a lifeline insurance program that serves about 75 million people in this country. That is, Medicaid is done 56 different ways because it's a state and federal partnership. And so it's done with all states, the district, and the territories. And our goal is to improve the quality and access to care for individuals on Medicaid and their families, because we know that it's such a large component, a little bit over a fifth of Americans, that it'll improve everyone's care. We consider ourselves to be a mission-based market enabler, and we facilitate cross-sectoral collaborative partnerships all throughout the Medicaid and health technology ecosystem. But our goal is really to radically change the pace of innovation. And we do that through educational programming, resources and tools to facilitate kind of cutting edge forums and partnerships with many individuals. I personally have a clinical background. I'm an epidemiologist by training, spent a lot of time within the four walls of hospitals, and so saw very closely how patients' lives and people's lives were impacted by being on Lifeline programs. And so I really look forward to being a part of the discussion today.
Thank you. Gus, will you go next?
Good morning, all. I am Gus Cardenas. I am from Austin, Texas, and I am the CEO and principal co-founder of the Austin Healthcare Council. We are a group of individuals, actually organizations, that are looking to improve the health of our community through collaboration, leadership, and innovation. Our ecosystem, mostly around the US and not only here in Austin, is siloed. And our main goal was to break those silos down to be able to get the CEO level position to be able to work with each other. And so over the past 4.5 years, we've been able to accomplish that. We're looking to produce or develop systems or solutions in the healthcare space that are replicable, that can be replicated around the world and or around the US. We thought we could, because as y'all know, the healthcare ecosystem is vast and complicated and multi-layered. And so instead of trying to going out there and boil the ocean, we decided we'd look at Austin, see what we were missing here, find the gaps, find a solution, and then offer it globally or internationally. And so that is what we've been doing. We've been very fortunate and that the World Economic Forum, as I mentioned earlier, spotted us on their radar. We applied for their Healthy Cities initiative that they were launching this year in Davos, Switzerland. We were one of thousands of cities that were applying for that distinction. And they selected 3 cities around the world, Moscow, Mumbai, and Austin was the other one, which is kind of unique in that we really don't have a large healthcare system here in Austin, but we do have the IT part of the world that they were looking for. And what the 2 items that we're looking for in any healthcare solution for those people that are developing product and devices and so forth is at the high level, we're looking at devices or looking at solutions that provide preventative care and solutions to provide predictive analytics. Those are the 2 areas that we'll be focusing on in the healthcare space going forward, in that the current system that we have in the fee-for-service environment is not sustainable. And so I'll go into more of that when we start our talk, but I'll leave it at that. Thank you.
Thank you, Gus. Appreciate that. Stephen, will you go next?
Sure, I totally agree with Gus that FFS is not sustainable. I've been a healthcare CEO. I've also been a global reinsurance executive for many years. So that perspective is quite interesting. I never thought I would be on the healthcare side, but I got to be a CEO, and I learned some of the gaps and some of the areas that healthcare needs help in. And when you juxtapose that against, the reinsurance and the insurance and the alternative risk transfer world, it's really interesting. And I think both those areas merge together quite nicely. So I started a company to help people in those areas, like with payers, brokers, reinsurers like Munich Re, and folks out there like Swiss Re, to help them understand what the risks are. And one area that's really interesting, with risks that we're seeing out there as we become more of an IoT society, is cyber and cyber liability and cyber insurance, which are 2 different things. For example, real quick, you look at Fitbit. Fitbit has a fundamental problem. I don't know if anybody's a big Fitbit expert on here, but there's no identity. So I can strap my Fitbit on my pup and run my pup out in the park for about a half hour and get 10,000 steps, send that into John Hancock and get a $233 check from those guys. And I haven't done a thing but watch my phone and watch my NFL game on my phone. So when the dollars become into the tens of billions for these insurers and reinsurers out there with healthcare on cyber side, liability, or, IoT related, identity is going to be a big thing.
Thank you for that. Balint, will you go next?
Hello, everybody. My name is Balint Bene. I'm the CEO of Bene Studio, and Bene Studio is a digital product consultancy. We have a special focus on health tech, and we already delivered more than 100 premium quality mobile and web applications. And we also integrate systems for enterprises and for startups as well. Personally, I have a diverse background covering technology, design, and business. And into this panel discussion, I'm bringing the digital product strategy, user experience, and the software development aspects, and answering the initial question. For me, health tech for communities should be solutions helping the underserved minorities, like the elderly or disabled people. Basically, I believe that it should be in focus.
Yeah, absolutely. As you guys can see, our panelists are very passionate about this topic. So in this first 15-minute discussion, we're going to discuss a few specific topics here, one of which we already have touched on, which is the increasing importance of healthcare ethics in both product and user design. The second is rapid acceleration of health tech and identifying those communities that are being left behind. And then moving beyond the adoption of first adopters or first movers and the impact of digital therapeutics in this healthcare paradigm from sick care to well care. So in a previous conversation, we discussed these things, and Adamika, you made some really interesting points around reframing the thinking of technology, and especially for all of those innovators and entrepreneurs, in the audience today, how do you adjust your tech literacy so people understand your product?
Yeah, so first I'm going to speak to two different audiences, right? Because I'm used to speaking about 5 different languages because we have lots of stakeholders in our ecosystem. So I'm going to speak to the entrepreneurs first. So oftentimes when entrepreneurs think about developing a product, they think about the business problem that they're trying to solve, the intended audience, and then they think about how they're going to get something funded, right? And most of us have this this really clear set of how that timeline will be impacted. But oftentimes we miss steps where we often don't think deep enough into the problem statement in which we're trying to solve, and thinking about how that problem statement impacts absolutely everyone, and how can we develop design for products that don't create an ability to have to go back and redesign a product later. And I will say that oftentimes people come to us once they have, they've gone from pre-seed to seed or seed, and they're ready to go to Series A. And then they realize wow, how can we push our product into this population, right? We were focused on a commercial population in a very specific area and a very specific disease state. And now we'd like to move it to something else. I actually think that it's best to try to broaden your thinking as much as possible from the beginning. And I say that because, and I'll give an example. I often think of public health examples of being the easiest way to think about things. When we think about pedestrian crossing in this country, we kind of don't really think much about it. Most of us can just cross the street, right? But pedestrian crossing is designed not only with the user experience in mind, but the problem statement of being as broad as possible. Individuals with ambulatory challenges can cross the street. Young children can cross the street. Now, there's some pedestrian crossings that are more bells and whistles, flashing lights, auditory ways of communicating to get across the street. But most of us can cross the street effectively. I think sometimes in health technology, we're so fast to think about quick returns and moving to the next level, we often forget to think as broad as we possibly can. So a good example of that is like in maternal or reproductive health. In maternal reproductive health, there are lots of products, right? From conception through fertility, all the way up, right? Through menopause. But oftentimes we don't think about how is it that we make sure that we're including, quote, all women in the derivation of what women's health looks like. And I mean women with an X, right? And that really looks different. Because if you realize that the data says that 53% of the births in this country are Medicaid births, it'll have you really start to think about your product much differently. And also to utilize the data that we have available. A lot of times there's like misconceptions that are out there, like individuals in this country who are poor or who are homeless or who are differently abled don't have access to technology. It's very wrong, right? What we found is actually most people communicate through technology. The question is, how can you make sure that user experience and your product connect closer with a crosswalk? Now I'll speak a little bit just briefly to investors. And I spent a lot of time around entrepreneurs saying, investors are discouraging founders, to look at pursuing federal programs or government as a customer because it's too complicated and too slow. You're leaving an almost $650 billion industry on the table. That is, kind of a pretty large bucket of money. And I think we're seeing the tide change and have seen it certainly in the last 3 to 5 years, where more than social impact investors are thinking about government payers. The reality is, venture is a very small amount of the way that health technology and healthcare in this country gets paid, right? And not everything will have a 10x return, but the impact is so great, and the penetration, the market penetration. So when you talk about fast moving, when you get a state procurement contract or you align yourself with a payer that has got a government entity contract, the amount of people that you can impact just jumps tremendously at scale. So I think it's just a part of how do we start to think about expanding our user experience, how we include more people in our pilots that look and feel different, not to just get what we think is intended outcome of data on the back end, but to actually see how your product can be proven. Because a lot of times, a lot of the reasons why companies kind of spiral or have real difficulty at that Series A point is because they haven't thought deep enough about their problem statement to be able to penetrate and make significant clinical or objective outcome changes.
Yeah, I think Gus had a good point on that, where he said, you've got to follow the money to find the solution or problem. Gus, I don't know if you want to elaborate on that a little bit.
Yes, in fact, you need to find yourself a champion, and you probably heard this word before. And at first I was kind of irritated when I heard it, where you need to find a champion within a particular organization to help you move your product within that company. And so that's one of the things that we've been looking at within the council is how do we help our entrepreneurs in the healthcare space develop a widget that's going to help you and I get that widget to faster, quicker solution to the marketplace. I use an example. This is a real one where we had an individual, an engineer, phenomenal. He developed a artificial elbow, a prosthesis elbow. And he just this is what I'm going to do. So he took it around different players, and he found out that they would tell him, "Hey, this is phenomenal. This is great. This is the best thing. It's antibacterial, blah blah blah, and so forth." And then they would say, "This, by the way, the guy had already spent $500,000 to develop this, design it, and so forth, and got the his team around him." He went to some hospitals and orthopedic surgeons to be able to look at it. They said, "This is phenomenal. This is great." But the doctor says this. He says, "You know what? There's very limited real estate in that operating room. Can you make it smaller? 2, can you, by the way, the patient sits left to right. And is there any way, and I'm a left-hander, so is there any way I can be on this side of the patient and be able to use that same device?" You have to look at all those areas. So the first thing you need to do is go back another $500,000, another 6 months of development, and then you bring it back. The ones that suffer are you and I, the end users. So if there's any way you can find a way to get those people to help you in the design phase at the very beginning, they're practical people, that's very, very important. And that's one of the areas that we'll be focusing on with the council as we go further along. Our ecosystem, again, as I mentioned, in Austin is very small. We probably have 250, maybe 300 small companies in the healthcare space, and we need to grow that. But that's one of the areas that we're looking at. But go ahead, and I can continue unless Erica was going to add more to her part, because she's pretty fluent in that.
Well, I think you made some really good points there, and actually, I'd like Balint to comment, because you mentioned, in the product design. So, from a technology architecture perspective, how do we evolve to support these needs in our healthcare equity goals?
Yeah, let me join to the point of Gus, not just because I'm left-handed as well, but because it's a really, really important approach. And what I can see in the field of health tech is that nowadays the first wave of health technology solutions, they mainly serving the tech-savvy, highly educated, higher income users. So that people who are proactively consuming and demanding these services, applications, variables, and so on. And it seems a really lively ecosystem, but there are blind spots. And in contrast, when I speak about health tech for communities, then I can see unsolved health issues, mainly at minorities who can't access common high-tech high quality care or even prevention. And these abilities like cognitive, developmental, intellectual, mental, or even physical sensority, so all kind of disabilities, they are underserved currently. And I think these issues can be solved with a tailored HealthTech app and system approach. So when this new wave, this second wave is coming, then we should focus on the actual user experience of the applications, because the main difference is the different approach, not the technical background. So we should focus on that, and the key is the education, because mostly the underserved people are lack of the actual education needed to the proper use of the current mainstream health tech solutions. And also we need tailored special applications which can serve these special needs, like if somebody is not able to use the mainstream applications systems, then there must be an alternative solution, like with voice control or any other technical solutions. And these solutions are out there and ready. So we just have to combine the sensitive, user-centric, tailored user experience approach, and to combine that existing technologies which are already used widely and on the market.
Yeah, and I think that's an interesting point too about, you know, the disruptors making this go faster in terms of achieving health equity, and, you know, shifting that paradigm from fee for service to impacting preventative care. And Stephen, you had mentioned something earlier in terms of, you know, the motivators behind reinsurers and those who are actually motivated for preventative care. Wondering if you would, you know, comment in here, as well as possibly answer. There's a great question here by Baraka about, you know, how do we find these right people to work with, you know, and connecting them with long-term users in the design phase. So Stephen, if you'll comment, please.
Yeah, I mean, that's a hugely good question to delve into. What I've seen out there, you know, with the reinsurers and folks that are non-healthcare people, that they have to be shown, you know, where the efficiencies are and where the savings are and how it works. So when I contact folks, like let's say it's Swiss Re, Munich Re's major competitor there, they want to know what it means from a healthcare side, and then turn it into what it means for underwriting, what it means for the whole reinsurance underwriting scenario. And if you can show efficiencies and savings, and how it affects, you know, someone had mentioned the end user before. There's a lot of research that goes into, you know, who's being affected and how they're affected. So you have to do the insurance yourself on the front, or the research, you know, for the reinsurers or the insurers, or even the brokers out there yourself on the front end. And the beauty, I'll just tell you, the beauty of the reinsurers, the insurers, the brokers, that's a $7 trillion market that gets $7 trillion every year. It's not like buying a refrigerator once every 13 years. That's 7 trill going at it. And with life and health, which is called L&H in the reinsurance insurance world, that's about 55% of what's going on out there is 7 trillion. So what is that? You know, $3.9 trillion. That's a huge chunk. And with life and health, the health efficiencies are significant for about $4 trillion worth of that world. And another beauty of the insurance and reinsurance world is they don't talk to each other. The reinsurers do their thing, the insurers do their thing, the brokers do their thing. So you can sell it. You can sell into it 3 different times. So it's an understanding of the impact of the players that are out there. And really what I do is I try to find the end user and then go back through the system and bring meaning to the end user and then bring it back to my product. If that helps.
And Lindsay, if I can add to that part in there, the question that Barack was asking is, how do you get to those people? Most of you probably heard or have been involved in a reverse pitch. Have you all done those? If you haven't, you might want to look into those. Here in my neck of the woods, we're trying to get that going a little faster. And you normally pitch your product to someone to buy, to invest in, and to so forth. A reverse pitch is where you get the people that are in your particular market, the people you're trying to sell to, get them to talk to each other, get them to work a panel, or get them to work on a seminar of some kind, where they reverse pitch. They pitch to you what their needs are. And you as the entrepreneur then will be able to come in and do the, try to solve their problem. In most cases, some of these companies were willing to finance that particular solution if they think it's viable for what you've done. So that's something that you need to want to consider.
Yeah, I think Gus.
Go ahead.
Go ahead. I'm sorry. Yeah, I think that's a huge point. I think that's a huge point because the established companies, if you're an innovator, they have gaps. And I can tell you from being, what do you want to call it, an intrapreneur for Berkshire Hathaway, Warren Buffett's company, they're not good at, companies aren't good at innovation and change. So the entrepreneurs are. So what Gus says, is it's a great point.
And I also just want to ensure that we often think of misperceptions about what the right people are. When you think about government programs, which cover, when you add Medicare in, it's over half of Americans in general that are on government programs. You're looking at everything from, traditionally what people think, like individuals who are poor, or differently abled. But you're also looking at individuals who are genetically unlucky. You're looking at people who lost their jobs or had a traumatic life experience. And there are many different ways to think about how to involve the general community and population into user design. And certainly through social media, it has made things much easier to recruit and have people learn a little bit more about your particular product. I also think that, one of the things we do a lot is help, IDEO and larger academic institutions and, hospital innovation design centers, which almost every large integrated health system has, to think a little bit outside of where we would start to recruit or think about involving individuals into your pitch. And I think it's a bit like that reverse pitch thought process, going to your local faith-based communities and having a conversation with folks about what you're interested in doing and looking at how you can broaden your net of, one, potentially, super users or people that will evangelize your particular product. And I'll just give good examples. If you look at something like diabetes or other chronic conditions, there's a ton of people right now very concerned about chronic conditions because it's a comorbidity as you look at COVID and the increased rates, et cetera. What a great way to do some sort of educational program, align with Diabetes Educators of America or something, and find a way to provide a give, like some sort of something that people want, along with a bit of your pitch around what you're interested in doing, and pose it as a focus group or a way in which you're really trying to get people's feedback. I think the authenticity is the key.
And Lindsay, and I want to kind of push on that a little more. If you can look back kind of the 50,000 foot level, there are three verticals that you need to look at. Three columns. Column A is preventative care. Column B is your traditional fee-for-service model, and column C is your post health services, your home health care and so forth. If you can see yourself, find out which area you're focusing in. And by the way, the reason why I develop into those three columns is because if you follow the money, which again, I'm from the healthcare space, from the money side. If you follow the money, you find out why people are in that center column. The majority of our ecosystem and the money and development and devices and any kind of solutions are trying to go into that area. And that's because that's where you find the money to get paid by the payers, the insurance companies, CMS, and so forth. What we try to do, or we're trying to do here, is go from a fee-based model that, again, is not sustainable to a preventative care, go to that first column. But the reason there's very few people in that first column right now is because the payers and CMS, the government sides, there's very little money in this area. So you entrepreneurs, you're going to go where the money is. You're going to go to the middle. One thing you have to look at anytime you produce a product, look at that solution vertical. And that solution vertical, it could be defined as, I have cancer, and the doctor says you start you do all these things, and hopefully the solution means that you don't have cancer anymore. Or any other, you broke your arm, this is what you do to heal it. A lot of entrepreneurs are going to come in here and add another layer to that solution vertical. That is not sustainable. If your solution can take away a layer in that solution vertical of how to fix my arm, how to fix a headache, whatever the case is, then that will gain traction. If it's all going to do is add another layer or produce more work for the user, it's not going to work. So the idea here then is, how do you go to the first layer? And who's going to go there first? I had the CEOs from all the major payers come talk to us. Aetna, Humana, Blue Cross Blue Shield, United Healthcare, had them all lined up. They spoke for an hour and they didn't say anything. At least it was meaningful to us. One of my members says, well, we're going to do this, we're going to do that, we're going to go into this is what the CEOs were saying. We're going to start looking more at the preventative care, blah, blah, blah. An hour went by, nothing happened. Finally, one of my members says, well, what's going to make it go faster to get to that point? And there was silence at the front. And finally, one of them says, well, the disruptors are going to make this go faster. Who are the disruptors? They're your Walmarts of the world. They have 1.2 million employees. They're the Googles of the world. They're the Apples and so on and so forth that are self-insured because they want to keep their employees healthy. And so they're going to do everything they can to take care of them before they get sick. And in most cases, they have a clinic at the facility, or if you get sick, you go to work because that's what the clinic is at. So that's what's going to move these faster to go into that space. And you're designing whatever you're looking at, find which vertical you're going to be in, and then start looking at what are some of the problems in those areas that I can go try and solve. That's where we're going. There's some money in the third column, the post-care, and that's because a lot of us are getting old, and I got a lot of gray hair, and that's real, okay? You have to start looking at those, the older population. How do you take care of them and take care of them at home and not the other? The sustainable part that we have talking about, I brought in the National Health System from England, Lord David Pryor, who is the chair of the National Health System. We spent 3 days here in Austin with his team and our team to figure out what are the pros and cons within each other. Well, in the single payer system, which is an NHS, National Health System, they've been around for 78 years, one of the largest in the world. They're having issues with people because when you're in column A, your doctor says, I'm going to put you in the hospital. There's no room in the hospital. They can't get somebody into the hospital until somebody has moved over into their home health care area. And people can't go there anymore because people are living longer. And so that's making that time look longer and longer and longer to get into the system. So he came over to find out, how can we use ideas from what you've got that we can compare with what we've got? So a single payer system is great. It's what is considered a right to have healthcare. In the U.S., it's considered a privilege. It's got to have to blend somehow that we can make that happen. All y'all need to do as either investors and or in the entrepreneur side is decide what column am I going to be in. Long term, column A is going to take over. People of Adamika and her groups, people like United Way, people like all these other groups are going to be pushing more and more to people go into the section column A. I'll stop there for a minute.
I think, Gus, that's a great way to depict what's going on out there. The other question, for the entrepreneur to answer is, how do you get to them? You mentioned Walmart, and how do you get Walmart? How do you go after Walmart? Is it the CEO? Is it some guy, that runs, the health unit or whatever? I have seen in the last 6 months with COVID that the human resource people have been taken over. They've been taken over with COVID decisions. They've been taken over with diversity. And the CEOs are finally asking the CHRO, Chief Human Resource Officer, what do we do? And now the HR people have something to do and something to add. So I encourage, that other question is how do you get to them? And if you're doing enterprise, go after HR.
Yeah, I mean, there's a really great point there. As you're looking at human capital, I spent a lot of time with Microsoft. I spoke to Amazon last week. We spent time with Walmart. And while they are self-insured, they also have a range of employees. And oftentimes their executives to their distribution center, or their executives to their checkers and tellers and greeters, all look at very different demographically. I do think that ERGs and I spoke on Monday at the conference board, which is mainly the top Fortune 500 HR executives across the country, specifically around diversity, equity, and inclusion. I do think that there is more of a voice now with actual employees. And that's why HR is getting involved, because I think that the social impacts of there being an economic downturn, individuals having family situations at home, the reality is we lost almost 870,000 women in 1 month in the workforce between August and September. So I think companies are being forced to listen to their human capital because they're losing people, right? I think it is, for the first time, I've seen a lot more early stage companies get an audience, right, with what could be a harder client to have reached before. So, we have member companies that pitched to CVS, but, it took them 2 state contracts to get CVS interested. And you know how it works in startups, right? Once one person has you and you get a little bit of press coverage, then everyone's calling you like crazy and you're trying to scale up your company like mad, right? What we're seeing now is a little bit more of the seed and even probably very early stage companies getting a little bit more play, but it's that they have involved a very broad range of the population. So they can literally speak to almost every single one that I've seen, have been able to speak to the dynamicism of the time of the current environment and how their product is either able to impact on the loneliness and isolation space, or on the, caregiving space, or on the, cleanliness space, right? Or whatever space that they're in. And so I think thinking around how, I think all bets are off. I mean, we've seen in the last just 10 months alone that the funding for digital health is just going up and up and up. I think we're all kind of wondering how long this is going to be. But I think we've also seen the amount of companies pivoting and redesigning and rethinking also go up and up and up. And we've seen, I've heard very few horror stories about raising in this environment. I've pretty much spent a lot of time, once folks have pivoted, they've been able to really successfully raise in this environment. So I also think that there is a dynamism, though, to be in a global pandemic, to understanding the kind of cultural, racial and ethnic reckoning that's happening in this country, our changing political environment, and also what this is going to do with budgets in 2021 and 2022. And I think most people are saying now is it strike while the iron is hot, while people still have a budget, because I think we are in for some very challenging and tough times in 21 and 22.
Yeah, I think that's a really good point. And appreciate everyone. We're going to, I think, wrap up the panel discussion with ideally just a few lessons learned or key insights into what investors and entrepreneurs need to be thinking about as they explore bringing technology to improve the health of people and communities. And Adamika, I believe in a previous conversation, you said and this really stuck with me. There's just an obligation, if you are in health technology, to solve problems or make sure your tech solutions are impacting the health of the population over a return on investment, which I'm sure none of our investors will appreciate. But ultimately, as you just stated, there is an opportunity here. So with a 2-minute time limit each, I'm going to ask each panelist to provide their thoughts on kind of this value proposition of redefining the healthcare system with that in mind. And then I will wrap up the panel.
Yeah, I'm going to just basically talk a little bit about collaboration, because what we are seeing more than ever is if you are able to come in with another company, you're more likely to get these contracts. A lot of payers do not have the energy or the time to be dealing with the noise of, thousands and thousands of companies coming with them. So I think we've seen a huge success in collaborations, which sometimes turn into acquisitions, other times just turn into great ways for kind of partners to work collectively together. If you're a mental health or behavioral health company and you align with a company that's doing work in the reproductive justice space, like what a great alignment, and the way that you can go in together really leverages significantly. We've seen that with many of our member companies, and I think that's where, when the funds start to reduce and we start to think holistically, the way that you can spin your value proposition and really broaden your customer base.
Thank you. Gus, will you go next?
Yes, I'm trying to leave you here with some pretty thoughtful, insightful type, gray hair type wisdom with you. From the tactical point of view, what Adamik is saying is correct. I have been on the large scale side trying to look for large contracts to be taken care of by businesses. These small companies come to us and say, well, we have the solution, but they don't have the scalability to take care of us. So from a tactical point of view, if you can align yourself with a company that already has a contract with that particular large entity, you can now at the end ride their coattails, and they love you because they get additional work in there. So that's the tactical part. From the strategic part of the conversation going forward, I believe that there's the two items that you need to be looking at are preventative care in your solutions and predictive care in your solutions. An example would be that United Way, for example, has a 211 number where people can call if they have some kind of a social issue. I can't pay my rent, I don't have any more food, my kids needs a doctor, and so forth. A solution there would be that we put an AI type platform attached to that 211 that can now start gathering the data of what kind of calls are coming in. That one helps the call center take in that call and helps that person add additional questions to that caller so they can quicker, faster be able to get into the right resources to help the caller. Imagine being able to get that on top of an analytical, predictive model in there, where the system could tell you that based on the calls that we got in today, and just in little Austin, Texas, we get about 4,000 calls a day to that 211 number, which was elevated because of COVID. Imagine having those calls come in, and through this predictive model, we can now say that in 3 weeks or 4 weeks, we can alert our mental health area that we're going to have a tsunami of people committing suicide or having domestic violence in their homes. There's a number of things that we can look at by having the predictive model in place. So it's predictive and preventative. Those are the areas that you need to be looking for going forward.
Thank you. Stephen, your take on this?
I would add, with all the other great comments that have been out there, I would add that startups tend to develop the technology and spend a lot of money on the technology, but they don't spend the money on how to get there, who to talk to, how to monetize it. And I'll throw out there insurers, and what I mean by insurers are reinsurers, insurers, brokers, TPAs, anybody related, self-insurance, excess of loss, reinsurance, those kinds of things. Folks tend to make sure that they get the people that are in the IT side paid, but they don't think about how are we going to sell this? How are we going to monetize it? And what that means, to the folks that are monetizing it. So it's just a lot of homework. Gus was talking about the different silos. There are different buckets that an insurer, looks at that a startup can help them bring the solution to. And you just have to do a thorough job in all those areas and go through the tough questions. But don't forget about the monetization at the end.
Absolutely. A balance.
Yeah, so I totally agree with all the points from Ademika, Gus, and Stephen. And what I would like to add is that if entrepreneurs and investors both would like to reduce risk, because recently we've seen a lot of groundbreaking health tech ideas and really complex new technologies, and they grew rapidly to huge companies, even to unicorn startups. But after a few years, many failed, and it can be a potential risk if a new startup is starting its career. And if the entrepreneurs and the investors would like to avoid this really risky path, because this was mainly the result of the lack of real demand, then it can be a good approach to focusing first on a specific niche, like an underserved community, which we already discussed today, and after that, as a solid base, they solve real needs there, and they just refine existing approaches. They just dig deep into the perfect user experience tailored to that specific niche and that specific community. Then it can be a safer way to find and to build on a real market, to differentiate the application, the solution itself. And on the technology side, in many cases, it's possible to use already proved solutions, technologies, and don't have to take big risks on the technology side if the focus is the proper solution for an underserved niche. So it can be a safer way. Although on the other hand, maybe not that promising, like 10 or 100 or 1000x growth within a year or something like that, but significantly less risk on the other hand. So if startups and enterprises would like to go this direction, then these points may help them.
Absolutely. Well, thank you, everyone, all of our panelists. It was a wonderful discussion. Some really great takeaways, I think, for everyone here. Obviously, this is a really big topic, but ultimately, I think what I took away from it was that, there's many considerations in this explosion of health tech and innovation, but ultimately, I think considering, as Ademika said, the most common denominator in terms of user experience and really focusing and getting that right from the beginning is going to go a long way. So please join us next month on December 17th for another exciting discussion around health and technology. And for information on the monthly HealthTech Rapid Conference event series or the HealthTech Networking Club, please head to the Bene Studio website. I will now hand back the moderator role to Sandra Miller for the HealthTech Startup Award session. And thank you, everyone. Sandra, were you ready for me? Maybe not. Maybe we'll just talk about this all day long. There's plenty to talk about.
Yes, so basically,
and people can put some questions in the chat and we can keep going.
yes, we have this saved 5 minutes. So if Sandra is not available now, then we can use this 5 minutes for questions if Lindsay you would like.
Perfect. If there's any questions, pop them in the chat.
There was one question in the chat earlier that I know, I think we all started to kind of talk a little bit about, which had to do with, do we have any recommendations for founders on how to find the right people to work with on their design? Is there anything else that people want to add specific to user design?
Actually, the user is really important to create a proper design. So what we discussed today is that within the health tech space, it's not that easy to identify the stakeholders, the so-called users, because we not just having the end user who is pushing the application on the mobile phone, but we have the other stakeholders who are a bit hidden, but maybe with a lot of power within the ecosystem, like the physicians, like the different kind of finance channels, insurers, the companies, which was highlighted by Ademika, like more and more corporates are directly involved in the financing of the new solutions. So we have to pull together these real people from these different groups who are important for our service and our business model and our application itself, and we have to go through the whole concept with all of them from their perspectives, and we have to refine the concept and later the system, the application itself, with all of these different stakeholders, not just with the patients.
Yeah, and there was something else in the chat here I'm reading about. Stephen, you had commented on companies buying insurance and all insurance needing data. You know, from a health perspective, I don't know that a lot of people are as familiar specifically with the role of reinsurers and in terms of how to monetize this from an entrepreneurial perspective. Do you mind commenting maybe on some tips or ways that entrepreneurs can be thinking about that? Absolutely.
With the reinsurers, you know, reinsurers are just insurers of insurers. And then when you get reinsurance of the reinsurance, that becomes retrocessions. So they're looking at fundamentally, you know, the same data that an insurer would be looking at or a broker would be looking at. The beauty about dealing with a Munich Re, I think we had Munich Re on here, is that they can dictate to all the insurers that they reinsure what kind of data they need at renewal every year. So you should see, being at a primary insurer, any reinsurer, the month that the reinsurers need all the data, that's all the insurer does is run around and try to find the data. Now, I did mention a huge statement, and that was all businesses need to buy insurance and all insurers need data. And the monetization opportunity that if folks understand it, can monetize it very easily and very quickly. But I will tell you, you have to get to the right people. And that's kind of what I've learned the hard way over years of getting folks to the right people. There are people out there, but there are very few people that can move it and get it done. And you have to find those people. And when you do have a very compelling statement, you can convince these reinsurers and insurers, because a lot of times the innovation people do not come from doing insurance. They are hired because they're smart, and they're hired outside with no experience to come in and do innovation because they're smart. However, there's a certain domain level expertise in healthcare, and in insurance that you need to somehow acquire to help make the sale. And companies like mine, Sandquist Consulting, we get you there quickly and efficiently. You don't have to waste 2 or 3 or 4 years trying to get there and have the right message. So I think there's folks you need to talk to, before you make the final pitch into somebody, whether they can get it or not.
Yeah, and I think obviously this HealthTech Networking Club is a great resource for everyone to get connected to those right people. So I think we are now appropriately at the end of time. And although it was fun, I feel like we barely touched the tip of the iceberg on this topic in particular. But I will hand the reins over to Sandra for the startup pitch session.
Great. Thank you so much, Lindsay. Wow. So we go from this fabulous panel to hearing from the startups that are on the front lines, making things better. So welcome to the HealthTech Startup Award at the HealthTech Rapid Conference for November. I am Sandra Miller, CEO of Runway Innovation Hub in San Francisco. And in the background, this is what Runway looks like. And I'll be your moderator for this award. So we have a really terrific panel of judges, including Sidra Lafort, principal at Munich Re Ventures, Oren Aloni-Charas, CEO of Global Health Impact Fund, and Tommy Miller, senior counsel at Nixon Gwilt Law, and Balint Bene, founder and CEO of Bene Studio. So welcome to all of our terrific panelists. I am going to now ask each of the judges to briefly introduce themselves. And Sidra, let's start with you.
Happy to start off. So as a recap, I'm with Munich Re Ventures, the venture capital arm of Munich Reinsurance. I head up the efforts in investing in healthcare, covering both digital health, so opportunities that we were discussing just now about everything in digital health, digital therapeutics, chronic disease management, as well as sort of an insurtech space and looking at companies in health insurance and life insurance and innovating in that space. Happy to be here.
Great. Thank you, Sidra. Our next judge is Oren.
Hi, everybody. Thanks for joining. My name is Oren Aloni-Charas. I am the managing partner of the Global Health Impact Fund, and it's exciting to be here for this pitch.
Great. Thank you, Oren. And our next judge is Thomas, or Tommy.
Hi there, Tommy Miller. I'm senior counsel at Nixon Gwilt Law. My practice is really focused on life science innovation, but our law firm is dedicated to innovators in digital health, med tech, and life science. And so we do work with a lot of startups in those areas.
Terrific. Thanks, Tommy. And our final judge is Balint.
Hello, everybody. My name is Balint Bene. I'm the CEO of Bene Studio. Bene Studio is a digital product consultancy. We have a special focus on health tech. And I would like to share my 100+ product experiences today. And I would like to learn from you. And I hope that this event will highlight your products and can support you. This is why we are together, to help each other. And I hope that it will be as useful for you and for your products as useful for myself as well, to learn and to understand your points and your passes.
Terrific. Thank you. So the startups who will be pitching to us today, first we have Sloan Saunders, who's founder of IntelliHealth. We have, and they're based in New York. Conroy with MedSign, based in Arizona. And we have our next two startups happen to both be from Texas. Werner Vorster, who's founder of Vitals, and Samir Shah, who is with Valhalla Healthcare from Texas. So we hit 3 different states this time. So that's always fun to have people from all over the country and on our call. So here's how things will run. Each startup will have 4 minutes to give their pitch. And after the pitch, I'm going to ask the judges to briefly, if they have any questions for the startups to help maybe clarify something that the judges didn't understand. Maybe you want the startup to go deeper on a particular aspect of the presentation. And also judges, this is all about helping everybody get better. And we can all, with our presentations, always get better. And so any feedback about how to improve the presentation for next time is something that startups participating in this event will get from our judges. So after the Q&A, I'll ask the judges to score the startup pitch on a scale of 1 to 5, with 5 being the highest. And, we use a very advanced technology approach to do that, where we ask the judges to hold up, their fingers. So literally that's how we want you to give the score when I call for it. So it's very fancy. And then at the end of the pitches, the startup with the highest score will be announced as this month's HealthTech startup. And the winning startup will receive a planning session with Bena Studio to enhance the development of their product. And they also can get a one-on-one coaching session with Runway, i.e. me. So all startups participating in the session today are eligible for a free product discovery session from Bena Studio, which is very valuable. So let's get on with the pitches. So first, we're going to bring up Sloan Saunders. So Sloan, can you share your screen and let us hear you?
Can you hear me?
Yep.
Perfect. Can you see my screen?
Yep. Screen looks great. And so I'm going to be keeping time. And so I'm time cop and will call out if you're over time, but no one here will be over time, I'm sure. So anyway, let's go ahead whenever you're ready, Sloan.
Perfect. Thank you very much for having me. Sloan Saunders, CEO of IntelliHealth, and we are democratizing and scaling access to obesity specialty care. Where the journey for me started was with my wife when she started her clinical fellowship in obesity medicine at Weill Cornell. And one of the things that became very apparent as she started to do her clinical fellowship was the dramatic supply-demand imbalance in the market. So everybody is well aware of the obesity epidemic afflicting the US and globally. But what most people don't recognize is there are fewer than 4,300 obesity specialists in the US. That's leading to less than 2% of patients receiving appropriate care, even according to guidelines. To give you a comparison, that number for diabetes is 86%. So that's the problem that we're solving. We created a software platform that helps to train any provider, MD, MP, PA, that delivers 2 to 3 times more efficacious treatment than behavior lifestyle alone. We automate billing codes and reimbursements to help drive revenue at our customers while decreasing patient costs and improving patient outcomes. The journey starts for us on the patient-facing side with a very comprehensive dynamic questionnaire. And based on their answers in concert with EHR data or electronic health record data, our algorithms personalize an intensive behavioral therapy program that the Brigham and Women's actually did an 18-month PCORI-funded randomized trial on, and JAMA published 2 weeks ago. That leads to about 70% of our patients achieving a very clinically effective milestone of 5% weight loss. On the provider-facing side, we help to increase engagement on the providers to help drive adoption and adherence on the patient-facing side and give them guidance and recommendations around more advanced obesity intervention medical protocols. So we work in a whole host of different environments and with different healthcare stakeholders like the GI department at Hospital Corporation of America, within the employee wellness group at United Healthcare, with Mass General and the Brigham and Population Health, adult and pediatrics. Pfizer, we're working on some patient registry and data analytics, as well as an employee medical weight loss program, and more even at-risk populations like Indian Health Services and the Veterans Administration. We're a B2B software company, so we sell into these other businesses on a SaaS-based revenue model, so per patient, per month in tiers. And we have a lot of efficacy and expertise on the operations side. So I run the team as CEO. David Bass is our Chief Operating Officer, and he comes from technology and software space. Susan comes from Kaiser and helped to build KP.org. Dr. Aroni, one of our co-founders and Chief Medical Officer, was one of the co-founders to the American Board of Obesity Medicine, and my wife as a Senior Medical Officer. We're raising currently $5 million to achieve cash flow positive in 2022, and that's to fund key sales, marketing, operational hires, and go-to-market partnerships. We consider a lot of different options of possible monetization in the end. And really where we see ourselves going from an efficacy perspective is really outperforming most programs currently in market. This is a 2-year study that was done at the Weill Cornell, showing about 75% of our patients achieving a 5% weight loss milestone after a year and maintaining that weight loss after 2 years. That's compared to typically about 25% of the patients achieving 5% compared to traditional behavior lifestyle programs alone. We've also spent a lot of time on the cost saving side, and we're working with some of the payers, pharma companies to really understand the cost savings and shift of cost of care with our results in a whole host of different environments. And we look forward to finding ways to collaborate with other organizations that are in the space. So I appreciate you taking the time and look forward to answering any questions.
Can you just quickly mention, do you have an ask in terms of fundraising?
Correct. We're currently raising a $5 million price round.
Great. Thank you. Okay. Go ahead, Balint.
You're on mute. Yep.
Yes. Thanks for the presentation. I really like that you focused on the benefits for the different actors within your space. It's really useful and really important. And what I'm curious about is that the competitors.
So I don't have a competitor slide in this one, but most people, the market is on the whole, people perceive as very crowded. But if you look at where most of the companies are focused, it's either on the B2C side with behavior lifestyle like Weight Watchers or Noom, or on B2B and more other chronic conditions. So Livongo and Amada focusing on diabetes. We're really focusing on a whole new greenfield landscape of obesity weight management, which is just starting to take hold across the medical community. That's a surprising sort of differentiator. If you go to most healthcare systems, there are very few limited, obesity specialists. That's what we're changing. So our software platform helps to activate, train, and guide clinicians across specialties. So endocrinology, GI, bariatric surgery. We're working with HSS and orthopedic surgery. Obesity afflicts a whole host of 200 other chronic conditions, and we play more horizontally compared to the more siloed approach.
Thanks for clearing it. And just one follow-up, that isn't it dangerous that there are no competitors on that field?
Well, I would say there are a lot of different ways that people sort of address obesity. A lot of people focus on other chronic conditions. It's a very established field of medicine. So the American Board of Obesity Medicine, the accreditation body, was founded about 11 years ago by one of our co-founders, Dr. Aroni. Again, there are 4,300 specialists, but it's done in more of an analog environment right now. And what we're doing is digitizing and democratizing and scaling that access to that care.
Thanks.
Oren?
So thanks, Sloan. Thank you. That was an interesting presentation. I really appreciate that. And definitely obesity is a big problem that touches a lot of different other health silos. A couple of questions for you, one on the IP side and one on the finance side. What intellectual property do you have? It seems, based on your presentation, what you're doing is you're just codifying a workflow that's out there for public consumption.
So no, we actually want, my COO's wife is an IP attorney. We're using Carr and Fail out on the West Coast. We actually have gone through the trademark process and have a couple patents that were in the works on defending our algorithms that we've created to do that. And also at some point when the FDA starts to release guidelines on software as a medical device, we plan on pursuing that. So we do actually feel we have a lot of defensibility, both around our algorithms, but also how we built our technology. And we would be happy to show you.
But how would that IP prevent somebody else from getting into this space, since the workflow itself is not protected?
So one of our core technologies is our medication decision support. So based on the information we glean through our health risk assessment from the patients in concert with our electronic health record data, our algorithms actually personalize certain recommendation for medications and other advanced pharmacotherapy interventions that is proprietary. And as we start to learn from our outcomes, we'll be able to refine our algorithm and layer on some type of machine learning to really start to improve outcomes. So I would love to find a time to show you sort of our underlying technology, but there is a lot of defensibility there and proprietary.
Okay, great. Yeah, I think that's really important to show how you would protect, your product over time as it grows. The other question I have is with respect to finance. You are raising $5 million. What is your pre-money valuation on that $5 million?
I mean, we haven't come to specific terms with the lead investors. I would say the group that we anticipate leading or is in consideration to lead is probably high teens, low 20 on a post-money valuation.
High teens, low 20 on a post-money, so you're low teens on a pre-money. And I'm just curious how you come to a number like that. Your ARR is not very high. It seems very high to me. And you're bringing a lot of money. And so my concern on the one hand is that you may have a very high pre-money valuation, but on the other hand, raising $5 million on a low pre-money is giving away a lot of your company. And so the financial story is a little bit in conflict, in my opinion.
Yeah, happy to shed more light on that. I think, given our current existing customers like United Healthcare, HCA, the veterans, Geisinger, we have a lot of room for expansion from our existing customer base. And we can recognize, on a contract value, sort of multiple millions of dollars from that customer. We have a large pipeline as well. To date, we've raised about $3 million of third-party capital, and I've put in about $3 million myself. So I think going forward, we have gotten positive reception from the institutional capital partners that we've talked to, but I agree with being prudent in what type of valuation is appropriate given where we are.
Thank you.
Sidra or Tommy?
Yeah, I'll ask a couple questions. You mentioned, and this is, I have this written down, clinical decision support, and you mentioned pursuing software as a medical device. There is guidance and there are programs being approved through those programs right now. And you mentioned that you'd be waiting until there's more guidance out there. What is your regulatory strategy right now, and why aren't you pursuing that right now?
We feel where we are from a product standpoint, we have somewhat of a limited data set. We only have about 5,500 patients on the platform. As we start to grow that data set, and we're going to be refining our product, very iteratively, we want to get the product to a more stable state so we won't have to revisit that process because the product will be changing. So what we're trying to do is, as we start to get a more mature product, we'll then pursue that avenue. But we are, relatively early, I think, from a stabilized product perspective.
Is there a particular reason why you'd want to pursue device regulation or be considered software as a medical device versus staying out of the regulatory purview?
I think that's one of the reasons why we've stayed out of the regulatory purview at this juncture. I do think it adds a layer of defensibility. I also do think, based on how we built it, we'll be able to automate certain aspects of that care model. And so would we be able to, and this is the conversation we're having with some payers, get reimbursement directly? And so as we start to refine certain feature sets, I do think having that defensibility and accreditation will help to enhance our value proposition and monetization strategy.
Gotcha. And then my last question is, on your slide, you had mentioned a forecasted revenue of about $1 million for 2020. Did I see that correctly?
Correct.
And then, so it's November. Do you have a year to date on that?
We're probably 2/3 of the way through that. We have a couple large partnerships that I'm hoping to hit Q4. They might migrate into Q1, but they're definitely going to hit, and would love, for anybody that would have an interest to elaborate more on those larger partnerships. One's with 2 payers, one's with a large pharma company, and then a large hospital system.
Okay. Thank you.
So I would just add that, good job on highlighting some of the lighthouse accounts that you have there. That I think is very important when looking at a new solution like this. You mentioned that there are a few players in the space. You mentioned Noom. There are others as well. I just wanted to understand the reimbursement strategy a little bit, because the ticket price seems a bit high for the product. And when you're talking to many different stakeholders in the healthcare space, obviously that becomes a big issue. So just if you could maybe shed some light on that a little bit, that'd be great.
Yeah, absolutely. We view sort of the ecosystem as a spectrum. So you have behavior lifestyle on one end of the spectrum and bariatric surgery on the other. Our pure competitive advantage is in the middle, right? For most people, and that's probably 75% of the people that try behavior lifestyle, it's not successful long term. And so, that middle ground is really where we play by activating existing clinical resources. So from a cost perspective, we charge probably about $150 per patient per year. And that system is able to turn around and get reimbursement anywhere from $3,000 to $5,000 for that same patient. So we have very high margins, SaaS-based, type margins for our end selling into these systems, and they actually have about 90% margins, excluding the cost of their resources, getting that reimbursement level. So it actually is a very favorable ROI for those healthcare systems, and one of the driving factors of adoption.
Are you exploring revenue models that include the share of the cost savings that you're mentioning?
So it's a great question, and we definitely are having those discussions. I think, most of the even larger players that we're talking with are still unsure. We are working on an actual cost claims. We're using our claims analysis using actual claims data with a very large payer right now. We've implemented an employee weight loss program within their employee population. It will be the first of its kind published report on actual claims data. And that's some of the work that we're doing with some of the pharma companies as well, to correlate cost savings, medication spend, shift of cost of care. How we built that data analytics engine and platform, we view as defensible as well. So yes, in the medium term, we definitely are entertaining and even having discussions now on changing or doing a hybrid structure. But at this juncture, we're not taking on that risk, but we are starting to actually just correlate what those cost savings are given our efficacy.
Terrific. And judges, I'm now, let's transition. If you have one piece of feedback to share to improve the presentation going forward, or just sort of emphasize something you haven't said yet that you liked about it.
I can start. I think you did a great job as far as knowing your market, knowing where your strengths and where you fit in. I think with the presentation itself, maybe consider. I think you zoomed through a couple of slides there. So maybe trimming down, really kind of like highlighting what it is you want to say, because there were some of those points that I'm seeing as a flash, and I'm just like, ooh, I might have wanted to take a look at that. So, but overall, really good presentation, strong outlook.
Very fair. 4 minutes is hard.
Yeah. Yep.
Anyone else?
Yeah, I would just add that I think it would be, especially in this space, it'd be interesting to see sort of the competition landscape, especially with the players, as well as how they're thinking about their different strategies, whether it's fee for service or value-based outcome pricing, like Virta Health, for example. So I think that would have been really interesting to see as you talked about your own establishment of your ROI.
Absolutely. I can send you a very robust competitive landscape analysis that we've done.
Okay, one last question for you. What are your thoughts? And I know this question's always a bit of a crystal ball, but what are your thoughts on your exit strategy?
We actually have gotten a couple offers to date. We're not in the market currently. There are some strategic partnerships that we're looking. I think the most interesting conversations that we've had are with non-traditional players. So technology companies that have gotten into the healthcare space. Everybody's aware of the big ones like Haven, Apple, Google, so both traditional or non-traditional, I think, are probably, we're probably an easy acquisition target to people that want to branch into obesity, given that is probably one of the leading causes to most chronic conditions and diseases, or at least has a good underpinning. There's a lot of options, and we'll be very lucky to have those conversations at the right juncture.
Great. Thank you very much. Great job, Sloan. So now I'm going to ask each of the judges to just all at once, if everybody could do their analog scoring for us. Judges, let me see some scores. Hold up your hands. So we have, Oren, is that a 3? Yeah, okay. So we have 3 4s and a 3. Okay, great. Great job, great score.
Well, thank you very much.
Thank you. And now we're going to switch to Werner Vorster. Werner, if we could see your screen up and hear your voice.
Hi, everyone. I'm here.
Great.
Can you see my screen quick?
Yep, screen's coming up.
Let me quickly get a slideshow. There you go. So thanks so much for the opportunity. I'm Werner. I'm the co-founder and CEO of Vitals. I'm also the co-founder of this little boy, MJ, who suffered from febrile seizures when he was younger. That meant that he would get a seizure when he had a fever, either fast rising temperature or a high temperature. And back then we were looking for a technology that would alert us at the onset of this fever, so we wouldn't have to sleep next to him in his room when he was sick, constantly checking his temperature. We couldn't find anything, and in discussing these challenges with our pediatrician and other clinicians, we realized that the lack of continuous monitoring and the need for early detection is even bigger in hospitals. 75% of adverse events and preventable deaths in hospitals occur outside the ICU in intermittently monitored beds. That means that a nurse would come around to your bedside, measure your temperature, heart rate, respiration, SpO2 every 4 hours. It'll take her about 15 minutes to do that. And in between these patients, 8 of them who he or she serves or treats during a shift, they also have to clean and sterilize their equipment. So we've then developed a wearable device that is packed with sensors that monitors body temperature, heart rate variability, respiration rate, and SpO2 or pulse ox. Our devices are small, unobtrusive, flexible, they're waterproof. They're disposable, which is a big plus so you don't have to sterilize anything or recharge anything. And they come with a 5-day battery life on continuous monitoring, meaning if we monitor every second, our battery lasts in a 5-day, we call it wear time. And that's the average, or that's a little bit more than the average hospital stay worldwide, which in the US, I know it's 4.6 days. So we try to cover that. If you go into intermittent monitoring, that can extend it to weeks, even months, depending on how frequently you want the data. So the data that we collect is also sent to the medical record system, and here's how our platform works. The patient would wear a device. We would data using a relay. So we have our own base station, which is basically a little box that we place throughout a facility, and our devices connect to those, and they serve as a relay to get our data to the cloud. We also have a mobile app. So as soon as a patient is discharged from hospital, they would run this app on their phone. It would serve the same purpose. So make sure our data their data gets to the cloud. And from there, we can integrate into any EHR or any hospital system, be it a third-party analytics system or their specific health record system, and display the data there. In near real time, currently our lag from device to dashboard is about 1.2 seconds. So it's very quick. Our focus has been operative since the beginning. I say has been because it's always been that. Since COVID, we shifted to outpatient post-operative more than inpatient. Hospitals have kind of clammed up because their funding dried up or their customers dried up during COVID. And the use case there is mainly early detection of deterioration and reductions in length of stay and reductions in readmissions. So a patient post-operatively is at risk of respiratory challenges as well as, or possibly lead to sepsis. So those are two of the big reasons for readmission. And if it's detected early enough, it's an antibiotic, and you can avoid sepsis, which can lead to result in death, and it frequently does. There's another market that we have been looking at, and we actually run a study with a hospital system here in Houston for emergency departments, where they would use our devices to triage their patients as they come in and treat the ones who are rapidly deteriorating first to make sure there are proper throughput or good throughput from the ED to admitted patients. And what makes us unique is that we are the first and only current wearable that incorporates all of these vital signs into a single form factor. That's advantageous because it's one device that you place on a patient. It's lightweight, it weighs about 10 grams, and you forget about it. There's no need to calibrate anything during the patient's stay. There's no need to have 4 or 5 devices. The device is also waterproof, so a patient can go to a bath, shower, it doesn't matter. The other advantage of our device is that we've been cleared by the FDA back in July for pediatric patients as well, so 2 years and older. It's advantageous because current technology, mainly all the wearables are cleared 18 years and older because they use EKG. We use a different way to measure our vital signs, and that way of measurement that we use can detect higher heart rates, where EKG fails at higher heart rates. That's why they don't get cleared by the FDA. We also have patented the armpit for body temperature, respiration, SpO2, and heart rate, which means no one can measure those or a combination of those in the armpit without infringing on our patent. Our business model initially single use, so we sell devices, and as soon as we have enough devices out there in the wild, we'll start collecting data and monetize that data. So time series vital sign data is not available currently, and we can provide that.
Werner, you're just a little over time, so do you want to?
Just quickly on the team, and then I'm done. So my background's in business. I have one successful exit before. Louise, our COO, is strong in operations and financial management. Scott recently joined us as VP of Business Development and Sales, and Amin is our lead engineer. We've worked hard to build a strong advisory board with medical background. Everything's done. We're currently commercializing, and we ran studies with Texas Children's Hospital, University of Pennsylvania, and St. Mary's Hospital for Children. Thanks.
Terrific. Okay, judges. Let's see who has the first question for Werner.
I can start. So first of all, I think this is a really cool device, and I do see a lot of these wearable vitals technologies coming into more of a consumer-based setting or an at-home setting. And so I see that your target is the hospital. It doesn't necessarily jive with the story of why you started, and that's based on your son. And so I was curious to know, kind of leading into your particular background with your son in his particular case, and why your market shifted to kind of the hospital-based setting patient versus the at-home setting.
Sure. So early on, 2016, we joined in San Francisco, that's called Launchpad Digital Health. And we did a lot of customer validation then, because back then we were a consumer device, and kind of cold approached parents on the street in San Francisco, asking them whether they would use this on their kids, and stating the use case. And the overarching response was that they wouldn't really feel comfortable for their kids to wear a kind of an adhesive product for when they're sick. This was our problem, right? So we had that idea that it was everyone's problem, and it wasn't. So we pivoted back then to hospital focus for a few reasons. That's the main reason. Second one was that hospitals are used to placing stuff on patients. Patients are used to wearing stuff in hospital. The need in hospital currently for continuous monitoring, or back then even, was huge. And then the other thing was that we could make a device that is worn in hospital but also goes home. And with COVID now, the focus has really been on home, hospital at home, and we can provide that with a device that was initially cleared for hospital. So it's a clinically accurate device, now can be used in the house, which is nice, or better, I think.
Thank you.
Sure.
Lauren, then Balin.
Thank you. So Bernard, thanks. That was a really interesting presentation. As an anesthesiologist, this sort of information is near and dear to my heart. But I do have a question, or maybe more of a statement that I would like to have you emphasize perhaps more than you did. Wearables are now much more common than they were a year ago, 2 years ago. So we're very comfortable looking at those. But two things. First, you're not measuring blood pressure, at least not today.
Yet.
Right. And so I'm not clear as a physician how you can really do adequate triage in an acute setting without blood pressure. It seems incomplete. So I would argue that's not really a good use case. It's better for more intermittent, more monitoring of a patient who's assumed to be stable and maybe has some changes where intermittent blood pressures would be appropriate. But the other point I wanted to make was that I think what's more important in companies like this, because the technology has become somewhat universal, even though some people do it better and worse, right? I don't want to take away from your accomplishments, but the platform itself and the machine learning or artificial intelligence behind the platform that provides decision support for the providers who are utilizing the platform, I think is critical. And I would like to see in a presentation like this more of an emphasis on that than on the tech itself. And then I had one other thought that just escaped me. I apologize. So, but I think that's a big deal, and I think can be very, very powerful. I think you have the tools to do something very powerful, particularly since it's clinically cleared through the FDA. So that I think really could add quite a bit of value to this presentation.
Thanks for the feedback. Yeah, so blood pressure we are working on. We'll have it ready, say, mid next year. So that's something that's coming. We're aware of that we need that. We're not, I don't know if I mentioned, I don't think I did, we're not a device for ICU specifically. We're outside of ICU. So yes, intermittent blood pressure would be needed. We're working on continuous. And on the second point, yes, we have started work, we are starting work on, we have found a company to partner with on the background, the AI on our data to start providing insights. So we know that's the next step. What we wanted to do first is get devices out, get them into our product market fit, and then start working on that and providing those insights. At the moment, we can send, even though we collect continuous data, we can send that data intermittently to the medical record. So it could still arrive every 30 minutes or every 15 or however often the hospital wants it. So for now, we can provide that at their frequency or at their rate, even when the patient's at home.
Mm-hmm. Okay, and then lastly, it's important, I think, in presentations like these to talk about EHR integrations and your capacity for that, or not a lack of capacity, again, just because it's a cost center, if not anything else in the future.
Sure, yeah, so we are set up with a company called Redox, who will be integrating us, and their timeline is a week to 2 weeks. They were in any medical record system that they're connected to.
Okay, that seems ambitious.
Oh, yeah, no, it is. It is. They tout a week, but because they're a middleman, they basically take our data and translate it to the format that the hospital wants it, the medical record system wants it. So they already integrated into Epic, Cerner, Medical, eClinicalWorks, all of those. And we basically integrate into them, and it takes them a week to switch us on. You want to call it that.
Okay, good. Thank you.
Sure.
Balin had a question, and then Sidra.
Yes, thanks. It's a really cool device, and my question is more about your business plan. So what is your actual status, and what's your bottom up business plan?
Sure. So we're in commercialization phase now, and our focus currently is outpatient surgery for post-operative monitoring. We're also looking at acute and low acuity patients, so chronically ill patients with events, because we're a more episodic, if you want to call it, device, where we measure if someone is really sick. That's our focus area at the moment, and we have various conversations going. When COVID hit, we were in the process of signing up 2 hospitals, so we were being listed as vendors with them, and they put everything. So we're still kind of keeping that warm. We have now been listed as a vendor at UT Austin, or UT Southwestern, sorry, in Austin. And so hospitals is also part of the focus, but the timelines are very long for them. So that's why we went outpatient.
Thanks.
Great. Sidra?
Thanks. Werner, I really like the hospital to outpatient, the ability to sort of go from in the hospital to the outpatient setting. You focus a lot on the hospital part of the conversation. So I'd probably want to understand that a little bit more. A few questions, and I think this is kind of going on the back of what my other judges have said. It'd be good to sort of understand, the regulatory pathway, especially as you think about adding new measurements that you can include into the platform, and also thinking about a little bit about the infrastructure piece on the hospital side. You had there in your slide deck an advisor from Sotera. Sotera has actually gone through this process. It kind of reminds me about what they were trying to do at the beginning, where they were focusing on the hospital setting a little bit more. So I think that piece would be very interesting to understand, because that was where they had some trip ups. And then the other piece would be just to sort of understand, the false alarm rates and alerts, and because in the hospital setting there's a lot of alarms going off, so understanding how that affects the fatigue that folks face there would be important. And then I think, so those are most of my notes. Just understanding the regulatory pathway a little bit better, and that move from hospital to in-home.
Okay, I can touch on it quickly. So in terms of regulatory, what we've recently done is submitted a 510K, use ourselves as a predicate, and claim or submitted it as a special 510K, which has a 30-day turnaround. With blood pressure, we're going to use ourselves as a predicate as well, but that'll be an extended submission or normal submission, 90 days. And basically only we need clinical data for our blood pressure, which is done in a lab on subjects. That goal would be to get that submitted middle of next year, towards Q3 maybe. And in terms of hospital connectivity, we can also connect to their in-hospital router system, so router network. So we don't have to install anything. If they can receive Bluetooth signal, we can connect to it. And then the third one you mentioned was, I forgot. The third question.
It's more of a recommendation on sort of the the move from the hospital to the in-home setting, because I think that piece is what, at least to me, was the most differentiating across the other platforms I've seen.
Okay, thank you.
All right.
Can I ask one question? One more?
Sure.
Sorry. Could I ask you what differentiates you from BioBeat at this point, who is
Sure.
taking blood pressure and all these other vitals and has this deployment right now in hospitals and outpatient?
BioBeat is more of a long-term telehealth, home health type device, where we're an episodic device, as I mentioned. We're also on the chest, which means that we are, and that's kind of answers Sidra's last point, where there is much less motion, which respiration, blood pressure, and SpO2 is affected badly by motion, as any nurse and clinician would tell you. So with us being on the torso, there's a lot less of that. But we're also seeing, okay, so that kind of differentiates us. We're also cleared for pediatrics, which is another differentiator to them. And they have a great product, by the way. I think they have a great product, but it's a totally different focus than what we have. So yeah, that would be my answer.
Okay.
Thanks.
Terrific. Judges, just some of you have already been sharing some great feedback, but I just want to, before we move on to scoring, to see if anybody has any additional feedback to help Werner. Go ahead, Balint.
Yeah, so just one thing, it's a really well prepared story, and regarding the presentation, the time frame is really important because I wanted to understand a bit more the last part, the business part, the investment roadmap, and these aspects, and maybe a bit more careful balance between the different stories or topics would help to fit into the strict time frame.
Thanks, Ben.
Yeah, very good.
I just to add that, and I think somebody brought it up earlier, but I think it's really important to have your revenue model involved also in your presentation clearly.
Thanks, Ron.
Okay. All right, judges, it's your favorite time, scoring. So please help us with the score for vitals. 1, 2, 3, go. 2 3s, a 2, and a okay, so 3 3s and a 2. Great, thank you. Great job, Werner.
Thanks.
Thank you. And next we have Samir Shah with Valhalla Healthcare. Samir, can we get you to share your screen and hear your voice?
Hey guys.
I see you, hear you.
Let me share my screen. Can everyone see my screen?
Yes.
All right. Great. So let me know when you guys are ready.
Ready when you are.
Okay, awesome. So first I wanted to say thank you to everyone here for giving me the opportunity to speak on behalf of Valhalla Healthcare. My name is Samir Shah. I'm Chief Product Officer, but also a physician as well, who kind of transformed into getting more involved in the health tech side. And joining Valhalla over a year ago, we're essentially a group of physicians and data scientists who've come together to try to solve the current inefficiencies within healthcare for both the patient and the provider. And in order to understand the solution, we first need to identify what the problems are. Studies have shown that the EHR has been a very large factor for physician burnout, which in itself has become an epidemic in the world of healthcare. I myself am a result of physician burnout, and the documentation burden has significantly increased while the doctor-patient relationship has been negatively impacted. And then burnout, which has led to physical and mental mistakes, higher malpractice claims based on the lack of communication between a doctor and patient, and has created unreliability for the patient outcomes that have translated to approximately $188 billion in lost revenue. But imagine if we can close that communication gap, increase physician efficiency, and truly focus on patient outcomes. And so we at Valhalla Healthcare have come up with a solution that takes the basic level intake and supercharges it. So with leveraging clinical databases, correlations, interactive question subsets, we're able to capture a very large portion of the patient-provider interaction before they even see a physician. And so our intakes leverage true clinical content tied with our AI algorithms to ask very guided and specific questions. And based on the responses, we're able to build up a very detailed patient story. So what does that do? That translates essentially into, we take all of that information in the intake, and once it's completed, we move it over, all the data is translated into a very composed draft EHR note for the physician to read before they even see the patient. This not only helps the physician gain insight into the patient visit, but sets them up for success and efficiency right from the beginning while actively increasing that doctor-patient relationship. So our most recent solution, ValCare, takes everything that I just described and adds a telehealth component to it. So once the intake is complete, the patient can hop right into a virtual visit immediately. And so just imagine from the physician side, having that draft EHR note right then and there. So if you think about the world that we live in today, especially with COVID and folks being really worried about going to a hospital to even see their primary care physician, this is an opportunity to still develop that doctor-patient relationship without actually, and being able to streamline the care without having to actually physically be there. And just in general, the results lead to about a 720-minute reduction of note data entry per month. And so that's about 30 minutes per day saved without changing anything from the physician workflow. And the return is shown really in the data. Our draft note ties into clinical documentation improvement to generate the highest level of CPT coding you can based on the visit. Our providers can see 1 to 2 more patients per day, which generates more revenue. And our notes include all the elements necessary for auditing, and we have proved to decrease the number of denials based on our note quality alone. And then with a $5 billion total available market and a $700 million serviceable available market, our solution can be scaled up and scaled down based on the segments that we have, the ability to integrate seamlessly with any EHR in the market. So regardless on if you're an IPA or if you're a large-scale healthcare organization, we can embed ourselves within the organization to really be a seamless process. And our competition, not to discount any of them, since they have made their own niche, but they only address single elements within the market and are very basic to the key clinical correlations and physician efficiency aspects. So with Allevia, we instead take a holistic approach to this while also trying to specialize on better health outcomes. And then we have a number of partners and collaborations to date. So while also currently going through an implementation with a large healthcare system right now, CTCA, we've built up really strong relationships with Salesforce, Fruit Street Health, really tying into our core clinical content to really guide that patient interaction. And what we're currently doing in our round is we're closing our seed round to raise about $1.5 million and have set some very obtainable goals at Valhalla based on the future development and partnerships we've made to date, as well as our pipeline that we've built. So hopefully getting to $100,000 in monthly recurring revenue by Q3 of 2021. And so then in terms of our future products, take both a proactive approach and a reactive approach to healthcare. So as we leverage the incoming data to help mold better clinical decision support, patient engagement, early intervention, and a focus on chronic disease states, while also taking a retroactive data approach to help guide financial incentives and decrease the healthcare burden, not only on payers and healthcare systems, but truly on the patients themselves. And so here's just a snapshot of our team. I'm very blessed to be a part of a group of individuals who align on a vision of better healthcare for everyone. And yeah, that's it. Thank you guys, really appreciate it.
Thanks, Samir. Judges, questions for Samir?
I had a clarification question.
Sure.
You mentioned that you had one system that had signed on and 726 physicians. And so is it being pushed down by the system to the physicians, or how does that currently work?
Yeah, so the large healthcare system that we've signed on is separate from the 726 physicians that we have to date. That's through our independent practices that we have worked with and started billing our monthly recurring revenue. And then the large scale health system is an oncology healthcare system, CTCA, and we're now embedding with almost about 2,500 physicians in a phase-by-phase approach. And so we sign on with a healthcare system, and then we do more of a proof of concept with in a phased approach to truly start impacting the specific specialties that are related to the field, and then making sure that we're very tight with our integration strategy as well as the content that we're developing, so that there's no there's no lag in terms of the implementation that we can do.
Got it.
I have a question, Samir. First, I enjoyed the presentation. I thought you did a really nice job. I was wondering if you could talk a little bit more about the clinical decision support, and also whether or not you have been creating records within certain silos of medicine, or whether this is something that all specialties could utilize.
Yeah, so first of all, with the clinical decision support, when we think about clinical decision support is a very broad topic, to be honest. We think about it from the medication perspective, we think about it from data analytics, we think about what we can truly provide in terms of insight for the physician in order to make key informed decisions about care for their patients. And so when it comes to our initial standpoint or our initial technology, that clinical decision support is a very basic concept in terms of making sure that the provider has all the key elements necessary to make an informed decision for their patients. Now, as we're moving along through the future development, we're now tying in key clinical data sets claims data, utilizing a lot of APIs and partnerships in order to align ourselves with medication, clinical decision support. So more so of tying in with key specific symptoms and certain disease correlations to really help guide medication relevancy and also price strategy for those medications. Then we're also tying into chronic disease support. So working with a lot of current healthcare systems where we're tying in with diabetes management programs and making sure that we're providing really risk associations so that these patients are able to feed in their data, and then based on those insights, be able to then prospectively help impact other patients who might be able to have the same exact conditions or key correlations that we've seen in the past. So from the clinical decision support, it's a constant, evolving model that we're building. But I really like to say that our insight initially right now is what's driving a lot of physicians to really streamline the care that they're be able to give. And then when it comes to our markets or the specialties that we're targeting, it's everyone. What we've been doing is we've been building up a lot of our primary care content because that's who we've been impacting currently right now. But as we're moving along through the impact with CTCA and a few other organizations, we're starting to build up a lot of our key oncology content and a lot of specialty related content in order to kind of round out our entire solution. So we technically have probably about 85 to 90% of our key content that could address the entire market. But as we get detailed, of course, we're never going to hit 100%, but we're trying to achieve that as we sign on more systems and have those partnerships so that we're not burning a lot of resources in the meantime when we don't need to for additional content development.
Great. Balint, you had a question, I believe? You're on mute.
Yeah, so first of all, I really enjoyed the presentation. You fit into the time frame, highlighted that important areas which helped me understand the whole story. So it's a really good job. And I'm curious about your place, how you define it in the value chain. I'm curious about the indirect competitor landscape because your solution is somewhere in the middle of a quite crowded space where you highlighted the direct competitors, but I think it's important to see in a wider aspect.
Sure. Yeah. So, thank you for mentioning that. We do play in a space that has multiple angles of competition. We like to see ourselves fit in as more of a virtual scribe, and not to say this in a negative way, but a virtual scribe on crack. We have different elements that we tie in. So from the data correlations and perspectives, our competition is, a lot of key companies that are, tying in AI and artificial intelligence, but not really having a clinical lens attached to it. So, they might be providing the actual data for patients, but what are they doing with that patient data? They're just uploading it to an EHR or integrating with a healthcare system and forcing the healthcare system to make the decisions. When it comes to our intakes and guided intake forms, a lot of them are very basic in terms of what they can do in terms of development for their patients. So when you think about, how they're building their key clinical correlations, how they're building out their actual data sets, they're not guided by the physician lens again. They're more guided by, here's a form, let's translate it over to, being able to enter it in digitally, and let's have that data transferred over into an EHR. And realistically, that's not helping solve the problem. And what we're seeing is that, yeah, you might be saving a few minutes in terms of efficiency from the aspect of having everything digitized, but at the same time, what are you doing with all of that information? You're not translating it over to anything important. And then when it comes to our competition, especially from the virtual scribe aspect, we have a ton that are out there in the market. Even when you think about when I was practicing as a clinician, we used Dragon or M-Modal as a mode of vocal dictation into the EHR. And that was another element to increase the efficiency for note taking. But again, these are all processes that are forcing the physician to do additional work or forcing them to do things which we can easily increase the efficiency for. So we can decrease the amount of time that you're actually documenting with and be able to translate that to more interaction with the patient itself. I always think about the story I always come back to is just my inability to actually have built up a better communication channel with my patients. And I was dealing with a lot of, I'm a gastroenterologist, and for me, it was really, how can I communicate with my patients better in a more meaningful way? And I felt that I was forced from the organization to really make decisions based on how much data I'm entering into the system. What's the maximum I can bill for? All of these XYZ elements that I wish I didn't have to do necessarily, or I wish I had efficiencies built in where I can have that taken care of. And so as much as
we're going to have to, Samir, I have to cut you off. Samir,
sure. Go ahead.
We're running close on time.
Yeah, sorry.
So
I hope that answered the question.
That's okay. Love the passion. We totally get that. But we are out of time for questions.
Sure.
So judges, I do need your help with the score for Samir's presentation. If you could all show me your score for this company. So we have a 4, a 3. Okay, a 3 3s and a 4. Is that correct? Yeah. Okay. All right. So thank you very much. So that means that first of all, I want to thank all the startups for your pitches today. Startups, we're really grateful for the privilege to hear about what you're focused on day in, day out, and to make patient care and healthcare better. And judges, thank you very much for the terrific questions and insightful feedback. I think our startups really got some great stuff today. And as I mentioned, no one walks away empty-handed. So every startup participating today is eligible for a free product discovery from BeneStudio, which is really awesome. And the prize for the winning startup, they also can take advantage of both one-on-one coaching session with Runway and to dive deeper on these things, and product discovery and planning session with BeneStudio. So the winning startup will get lots of love and will be highlighted as the HealthTech Startup of November with an exclusive interview published on the HealthTech Networking Club page and across BeneStudio and Runway social media channels. So the results are in, and Sloan Saunders with IntelliHealth is the winning startup for today. Thank you all for attending November's HealthTech Startups Awards, and a big congratulations to IntelliHealth. So for more information about anything you've seen today, the networking club, and we're just so happy to have this growing month after month, and being able to connect startups, investors, and healthcare providers, and other key players in the health tech industry. So please go to the BeneStudio website to learn more information. And our next event, the December event, is going to be December 17th for the next HealthTech RapidConf. If you just want more, please feel free to check back in, because every networking session we learn new things. There'll be another fabulous panel. And thanks again to Lindsay. Lots of great feedback for Lindsay's terrific moderating of a great panel session. And so with that, we will get you out just almost on time, and respecting your time and knowing everybody's so busy. Thank you, everyone, for participating. Have a great rest of your day or evening, and we'll see you next month in